Hello everyone, I'm Michael Rubin, a neurointensivist and medical ethicist at UT Southwestern, and today I'm going to be talking about covert consciousness. We'll start out with some definitions of covert consciousness, then go into how do we assess covert consciousness. We'll review the ethical implications of such a diagnosis, and then I'll offer some tips on how to work with families regarding such a diagnosis. Now, by means of definition, disorders of consciousness are a disruption in the normal arousal and or awareness of a patient. Coma specifically is the absence of either of these. The unresponsive wakefulness state is a state where there is arousal without awareness. Minimally conscious state may have both arousal and awareness, but that awareness is limited, inconsistent, may have elements of language. And then sometimes we extend this to an emergent conscious state or a confusional state if a patient were to so improve. I think it's worth noting that these diagnostic categories are based on direct observation or an action that we provoke. And so they're limited by the physical exam skills and what we take the time to do with the patient. Covert consciousness is different in that we believe they can have an awareness of the environment, they're alert, they can process that information, yet there's some barrier to their expression of their understanding. Our traditional neurologic assessment is written out here, it's very detailed. However, we often will pull this information together into a established scale, which allows high inter-rater reliability. You can get a number from one neurocheck to the next or one shift to the next. They do have limitations, though, that they're designed for a specific purpose. So what's taken it up a notch is this development of the Coma Recovery Scale revised version, which looks at not just the typical neurologic exam, but other elements that may have relevance in the chronically impaired patient, which hopefully brings up some element of consciousness that was otherwise not noted. And people have looked at repeating this observation multiple times on patients to see if it would change how we categorize people. And in fact, it has shown to be more effective if it's used repeatedly. So this is a very nice picture that kind of illustrates how we move from classic exam to the CRSR. We find a whole other group of people that may have consciousness, to functional imaging that is going to identify another group. So maybe 15 to 20% may actually have consciousness that we are not able to detect otherwise, or covert consciousness. The technology we use includes functional MRI as well as EEG. So instead of just measuring a static state, we measure a dynamic state of their response to an environment. We'll offer some tasks, some objective. Imagine you're in the house. Imagine you're playing tennis. We do this with normal controls, and then we see what lights up, what electrographic patterns develop, and establish those as the population norms, and then compare it in patients to those normals to see what they might actually be able to perceive and understand. I think it's important to note that we have an expectation of ability to follow commands, just as we need some benchmark we can all agree on, that consciousness requires not just a response to the environment, but ability to process it and to execute an action or perform a thought. Functional MRI is probably has the most evidence behind it. This uses below oxygen level dependent signaling that changes as neuronal activity changes. Patients asked to perform a task, and then we see how the bulb changes. This is highly dependent on regional analysis and complex statistical modeling, which is way beyond my experience as an ethicist. But apparently those people that know what they're talking about say that this works quite well. Task-based EEG does something very similar and often involves quantitative EEG, complex computer modeling, machine learning, and AI to describe what they're thinking and how their activity and their cognition changes in response to request for a command to change. So how common is this? Well, in this particular study, 2 of 54 patients that had no bedside activity could demonstrate consciousness through a functional MRI. This study looked at both functional MRI and EEG in the acute setting of traumatic brain injury, and found that covert consciousness was in 4 of the cohort, including 3 that were described to be in the unresponsive wakefulness state. A more recent study used EEG on all comers with brain injury into their ICU, used machine learning-based technology, and found that about 15% of them were unresponsive patients, had EEG detection on day 4, and interestingly enough, half of those were able to follow commands before discharge. However, it's worth saying that 26% of those patients that did not have detection were also able to follow commands. So there's certainly not a claim that if you don't have the ability to demonstrate covert consciousness doesn't preclude the chance of recovery. This is still early information that says we're looking into things, we're getting a greater understanding, but it's not a must-have in order to have a potential for recovery. So how do caregivers respond to it? This group did a guided interviews of long-term prolonged consciousness impairment patients, and found that before and after, if they sat down and talked about their expectations or understanding, that the average person could indeed understand the concept of covert consciousness. Some responded positively when they were told that their loved one did have some semblance of understanding. However, there was mixed results for those that didn't have the ability to demonstrate consciousness. So what can we do with this? What's the ethical implication? I think we can say that the claim that consciousness is a continuum, of which we've defined certain points on the line, is expanding. We're now coming up with new ways to assess that consciousness, which is exciting. I think we still need to have the humility to say this is a small amount of the population. I'm sure a lot of loved ones of unresponsive patients would love to think that their loved one is the one that's aware. However, that might be a horrifying thought to others that would think that it would be terrible if their loved one was aware but couldn't communicate with the world. So like always, I think we need to assume psychological diversity. People have different values. The information is going to mean different things to them. And it may or may not help people that are making clinical decisions. But certainly, this is an exciting area. It needs further development and research. And I thank you all very much for listening to my presentation today.